Thank you, Dr. Siegel. I want to thank everybody at Discount Medical Supplies for inviting me to do these presentations. I enjoy doing them. I hope everybody else does too. So let's get started. I'm going to be switching the slides on your screen right now. You should see them switching. Today's topic is DC, MD, PT integration. I'm going to go over the basics of the setup and some of the most common codes that are used in a typical DC, MD, PT integrated practice. Tell you a little bit about myself before we get started. I am a chiropractor. I practiced for 16 years. My first 12 years was chiro only, and then I integrated and formed a multi-specialty practice. About 10 years ago, I started a company called Target Coding. Those of you that are familiar with me are aware of what I do. Those of you that do not, our specialty is showing you how to bill and code properly. We're not a billing company, but we show you and your billing companies how to bill and code properly and document properly. Our goal is to make sure you're documenting properly so you can justify the services you're billing, and then we'll show you how to maximize reimbursement. So I am certified in CPT coding, certified in healthcare compliance. I write articles for many different publications. I speak for the Coding Institute, Parker Seminars, Foot Levelers, and I'm a guest speaker at many national and state chiropractic association conventions. We have a whole bunch of seminars coming up, so you might want to check out targetcoding.com for our upcoming seminars. Okay, so now let's talk about the DC, PT, MD integration. There are pros and cons to DC, PT, MD integration. It's not all fun and games. Some consultants paint these rosy pictures that becoming an integrated practice is the best way to go, and it's the only way to survive in today's healthcare environment. I disagree. You can do very, very well without integrating. So to me, I don't push integration. I don't push staying a solo practitioner. To me, it doesn't matter what you do. So if you become an integrated practice, then it matters to me that you're billing and coding properly. If you stay a chiropractic practice only or medical practice, that's fine too. So there are pros and cons. And out of every 10 docs that call me that are looking to integrate, I'll talk 2 of them out of it because it's just not right for them. So there are definitely pros and cons to this. So let's go over a few of these. The positives, it's a great way to co-treat patients, adds another dimension to the practice. When I brought on the other doctors in my practice, it was great to share patient presentations. If there were patients that just were not getting well as fast as I wanted them to, it was great to have other healthcare professionals there to help guide me into the right direction and even take over on a few patients. If you bring on a PT or a nurse practitioner, you don't have to, as a chiropractor, you don't have to do the modalities or therapeutic procedures. It's definitely going to add a lot of marketing opportunities. You're going to have patients being referred to your practice from other healthcare professionals that would have never referred to you if you were just a chiropractic practice. Now that you have other services like physical therapy, you'll start getting referrals. So those are some of the positives. There are some negatives. You're definitely going to have more overhead. You may need more room. I was just speaking to a doctor recently. He has 450 square feet, and he wants to bring on another healthcare provider. He wants to integrate. Can't do it. Just doesn't have room. It's going to add more work and confusion to your existing staff. When I first started my multi-specialty practice, one of my best CAs quit on me because it was just too overwhelming for her. So she actually, 3 months later, she ended up coming back and loving it, but it was just too much for her. So you want to, understand that there are some negatives to this. Overall, I think it's a great thing to do, but, there are some negatives. You're going to have, you may have to cover the malpractice costs of all the other healthcare providers that come in. Now, how do you go about finding clinical staff members like MDs, PTs, DCs, PTAs, NPs? When you see NP, that's nurse practitioner. So think about that. How are you going to find these healthcare professionals? Well, one of the easiest ways to do this is just ask your patients. and it's free. You don't have to pay, like putting an ad in the classified section of the newspaper. You could just ask your patients. They could be your best resource. Check the local professional schools. There are hundreds of physical therapy programs out there. There are hundreds of nurse practitioner programs available. As far as chiropractic colleges, there are about 20 in the country. There are hundreds of PT programs, so you should be able to contact some of these schools. They may have a job placement department. Call your local medical offices and physical therapy offices. Check your local hospital website. Do a physician search. That's how I found one of the doctors that worked for me. He was the local chief of internal medicine at the local hospital. Contacted him. He was interested in working with me. We were negotiating back and forth. I just couldn't afford what he was looking to get paid, but he was a very good candidate. There are also placement agencies. If you're interested in a placement agency, please send an email to amy@targetcoding.com, amy@targetcoding.com. We'll give you the name of a staffing agency that could help you find a PT or a PTA or a nurse practitioner or an MD or an associate chiropractor. Before we get to the corporate structure, let me just talk to you a little bit more about what you should put in these classified ads. If you're going to need to spend money by putting ads in the paper, like your local newspaper, Craigslist, Monster.com, these are some of the places where you could put ads in. I've had many docs that I work with find their PTs online through Craigslist. You want to outline some of the things that are going to be going on. For example, you may want to put in the ad that the medical doctor or the NP or the PT is responsible for evaluating patients, planning, directing, and administering treatments in order to produce effective outcomes, coordinates and delegates and supervises responsibilities, communicates and assists in resolving problems, participates in training, understands and complies with the office compliance program. Obviously, you want your medical doctor, your NP, your PT, your PTA, your associate doctors to all know the clinical rationale and how to administer modalities, therapeutic procedures, orthotic devices, DME, and knows how to instruct patients on home care instructions. You want all clinical staff members to evaluate patients' response to treatment and progress towards goals. Anybody you bring on, they need to know your computer software program for documentation purposes. I'm working with some offices now where the chiropractor is using one software program. The MD is coming in and using a different software program. The physical therapist is handwriting her notes. Everybody's all over the place. Let's get everybody together on one software program. In the ad, you may want to put something like experience is desired but not required. In some areas of the country, it's very hard to find a physical therapist or a nurse practitioner, so try and get as many potential candidates as possible. Maybe you want to start out part-time. Is speaking another language important? You may want to indicate that a background in sports injuries or post-surgical care would be important. And then you may want to just add a little information about your particular practice. It's a great position to work with a great company. We emphasize high-quality care and professional growth. You want to offer health insurance and continuous education packages. Many of the docs I work with, you have to get a PT or a PTA that knows and has experience with manual therapy and deep soft tissue work. You want to mention in the ad that it's a pleasant working environment, state-of-the-art facility, competitive benefits and wages. These are a few of the things you should use in your ad. Now, again, you may want to start out part-time. You want to put the salary right in the ad? Great. You want to put in the hourly salary or the yearly salary? Go ahead. Do you offer profit sharing, benefits? These are all ideas. that you could put in your classified ads. And then you want to end the ad by saying send your resume and references via email or fax. You don't want to have 50 or 100 phone calls coming in. It's too time consuming. You can review the emails and faxes, and you could use that as a pre-screen and then contact the people that you think would be best for your position that you have available. Now, sometimes I get asked, well, why would a medical doctor want to work for a chiropractor? Why would a physical therapist want to work for a chiropractor? Well, good question, right? Well, I could tell you the answer. These other healthcare professionals, they may not be interested in running their own business anymore. They may have had a business and they don't want to do it anymore. I'm sure those of you in practice for 15, 20, 25 years, some of you might be, you know what, I don't want to run my practice anymore. I just want to be an associate. Could show up at 9 o'clock, leave at 5 o'clock. Yeah, some people would prefer just to be a regular employee and not have to worry about all the headaches that come along with running a business. So that's why they may want to work for you. Maybe they only want to work part-time. Maybe they don't like the hospital setting. Maybe they're just looking for more experience by working for you. You ever have an associate doctor work for you? They're not there for the long term. They're learning as much as they can so they could open up their own business. That's okay. Maybe the medical doctor is not entrepreneurial. The physical therapist just doesn't like new patient marketing, But once you find a medical doctor or an NP or a DO or a PT to work for you, try to find one that's chiropractic friendly. Explain how you manage a typical case and see if they're in line with what you want to do. The next thing that you need to think about when you bring on an MD or PT, an NP, even another DC, is get them credentialed, NPI numbers, Medicare P10 numbers. This is all part of creating and running and overseeing and managing a multi-specialty practice. Most of the multi-specialty practices that I work with, the chiropractor is the captain of the ship, because the chiropractor typically has the most business sense, is the most entrepreneurial, is the rainmaker, better than most MDs and PTs. So the chiropractor is going to need to coordinate all the Medicare P10s, get everybody on the plans if you want, credentialed. You're going to have your CA maybe get everybody credentialed, get everybody's malpractice policies in place. You may want to contact the existing plans, notify them of the new providers. If any of these providers are existing Medicare provider numbers, you have to get that Medicare 855R form filled out for a reassignment of benefits. So, you want to make sure you're aware of all the in-network rules on multi-specialty practices. Now, I mentioned nurse practitioners. These are wonderful individuals to have part of your team. Nurse practitioners, NPs, they've been providing acute and specialty health care to patients of all ages for nearly 50 years. They can assess typical neuromusculoskeletal conditions such as headaches, neck pain, back pain, disc problems, and other common conditions like chronic fatigue and diabetic neuropathy. They can manage weight loss programs. They can order DME as well as perform and interpret many diagnostic tests. They could initiate care plans, administer common procedures like traction, ultrasound, therapeutic exercises. Now, they have to complete a master's or a doctoral degree. That's advanced training beyond their registered nurse degree. There are about 155,000 practicing nurse practitioners in the U.S., so you should be able to find one. Their average salary is about $80,000. They're licensed in all 50 states, so consider bringing on a nurse practitioner. Now, let's talk about the corporate structure. The corporate structure. Before I get that, I just have to read this disclosure. The following corporate structure information is for educational purposes and is not intended to be and is not legal advice. The laws, rules, regulations regarding the establishment and operation of a healthcare facility vary greatly from state to state and are constantly changing. Target coding does not engage in providing legal services. If legal services are required, then you have to get an attorney. Regardless of your corporate structure, you must contact a healthcare attorney prior to seeing patients in your practice to discuss your corporate structure options. Even if you're an existing integrated practice, we strongly recommend you consult with a healthcare attorney to discuss your present corporate structure. So it basically comes down to three options. You are the employee, and then, you as the employer, and then you hire other healthcare professionals as employees. Next is partnership. You can become a partner in some states with another healthcare professional, and you could also bring on other healthcare professionals as independent contractors. So let's go through each one. Let's start off with the employer-employee. Okay, so you're the employer. You hire a medical doctor, a physical therapist. In some states you can, in some states you can't. I'll give you a couple of examples. In the state of New York, chiropractors cannot hire a medical doctor. In Florida, a chiropractor can hire a medical doctor. In South Carolina, you can hire a medical doctor, but you can't hire a physical therapist. In New Jersey, you cannot hire an MD, but you can co-own a corporation with a medical doctor. In Kentucky, you could hire a medical doctor, but you can't hire a physical therapist. Physical therapists cannot hire chiropractors in Kentucky. So you see how this can get very intense. You need to contact an attorney in your state that knows this. This can get very complicated, and if it's not set up properly, which hundreds of doctors have been set up incorrectly, it can cause major problems financially, fines, penalties. So you want to make sure. You can't just hire somebody. Now, if you're a chiropractor, of course, you could just hire another chiropractor, but can you hire a PT, a PTA, an NP, an MD, or a DO? You need to check into that. You need to get an attorney in your state. So when you hire somebody, you have much more control. The negatives are you're going to have increased overhead, increased billing responsibilities, increased malpractice exposure. You're going to do all the billing. The employer does all the billing under the employer's tax ID, and the employer pays the DO, the MD, the PT, the NP a salary. The employer receives all the gross revenues, less the MD, PT, PTA, DO salaries, taxes, and overhead attributable to the services. Make sure you get a comprehensive employment agreement in place. Very important. You need an attorney for that. Get an employment agreement with every clinical staff member. Next is partnership. You can become partners. Again, in some states you can, and some you cannot. Don't jump into this. Like in Georgia. Georgia's a very friendly state. There's no corporate practice of medicine act prohibition, so you don't have to worry about the corporate practice of medicine. So a chiropractor can bring on an MD, no problem. In Ohio, it's okay. In some states, you can't. In Minnesota, a chiropractor cannot hire an MD. So again, you have to check. Make sure you're doing it right. You might not be able to partner with an MD. So if you're listening to this, remember, there are a few things you have to go through as far as the corporate structure. Once the corporate structure is out of the place, out of the way, then that's where I come in and show you how to bill code and maximize reimbursement based on the services we recommend. So partnership is a fully integrated practice. You have full cross referrals, no Stark violations. Everybody's under one tax ID number. There's nobody else referring patients to this practice that has ownership in another practice. So you've got to be aware of this Stark and the anti-kickback and self-referral rules. Very important. Negatives, you're going to have increased expenses, liability for all partners and shareholders. If you want to break up, it can become difficult to dissolve. And then you want to have a comprehensive partnership agreement in place. You may have to form a medical corporation first and then hire other healthcare professionals. So you have to get a partnership agreement. Next is independent contractor. So this is nice. You can get rent, no revenue, no increase in fixed overhead. You're going to get increased revenue from the rent, no increase in billing administrative, no malpractice issues. You just have limited financial benefit when you lease out a portion of your practice. You're subleasing. Make sure you check with your landlord if you don't own the building to see if you can sublease a portion of it out. And it has to be fair market value. It can't be based on patient volume or referrals, so you want to have a sublease agreement in place. Next is patient flow. This is one of the most important things to go through once you're set up and your corporate structure has been set up. Now, who's going to see the patient first? Who's going to see the patient second? Can the person that saw the patient second see the patient first? Can a PT see a patient right off the street? Whose name is on the claim if the PT sees the patient right off the street and the MD is not on site? Whose name is on the claim if the MD is on site along with the PT? Can a chiropractor refer? There's all these different arrangements regarding patient flow. Who does the patient belong to? Very important. So let's just go through a few things. New patient calls to make the appointment. Your staff should ask the patient, are you calling for chiropractic, medical, or physical therapy services? That's a practice management question. Plant the seed in the head. Maybe this patient didn't even know. Let's say you offer massage. Patients don't know. Ask when the patient calls, are you calling for chiropractic or massage therapy? Patient goes, wow, I didn't even know you offer massage. So plant seeds in patient's head. Your staff should go through the normal questions. Is this accident related? Have you seen anybody else with a condition? Go through your normal questions, which are very important, and we do staff trainings on these things, specifically for your front desk. The people on the front line answering the phones, they have to be trained properly, make sure patients are brought in properly and all the information is gotten on the phone. And once the patient walks in, patient fills out a health history form. Make sure you have financial information on the form. Example, please understand your insurance is an agreement between you and your insurance company, and all services rendered to you are ultimately your responsibility. The patient fills out the form. Now, who's the patient going to see? They're going to see the MD first, PT first. Medicare allows a patient to see the PT first without a medical visit. Who's going to see the patient first? In most cases, it's the chiropractor. So if the chiropractor is going to see the patient first, chiro needs to do a history, exam, go through some decision-making, come up with a diagnosis, establish a plan of care, create goals, list the services that are going to be rendered to include the clinical rationale, writes up a treatment plan. Now, after this, the DC says, you know what, Mrs. Jones, I think you can benefit from physical therapy. Now the DC should complete a PT referral or order form. Again, this may or may not be okay in your state. In New Jersey, this is okay. In New York, it's not. In Minnesota, it may be okay. In Arizona, I don't think it is. In Virginia, it is. So, again, you have to check. It may be okay today, the day you're listening to this presentation, and next week the rules can change. I know a few states right now that there's legislation in the capital of the state that are changing some of the rules on this. So today it could be okay, next week it might not, or vice versa. Today it might not be okay, and the rules may change next week. Some states, they don't even have a ruling on it. Some states say, well, we don't know if it's okay or not okay. Now, if you're going to refer the patient over to the PT, obviously as a chiropractor, you cannot do this. You cannot refer or order PT on a Medicare patient as a chiropractor. So this is not something you would do on a Medicare patient, but all others, if your state allows it, you would create a referral order form for the PT. If anybody would like a copy of this form, send an email to amy@targetcoding.com. That's AMY@targetcoding.com, and we can send you a copy of this referral order form. Now, just a reminder, according to the Medicare guidelines, chiropractors cannot, I repeat, cannot refer Medicare patients to PTs, MDs, DOs for physical therapy services. However, chiropractors can perform modalities and therapeutic procedures on Medicare patients. However, these are not going to be paid by Medicare when performed or ordered by a chiropractor. Chiropractors are allowed to and should be attempting to collect the full fee for these services. Now, if an MD, an NP, a PA, a PTA, you're going to see patients there, Medicare patients, then you must get your Medicare carrier therapy guidelines, the physical therapy guidelines, the LCD, for physical therapy and medical procedures in your state. Don't gamble or guess. Follow the rules. Now, when it comes to decision-making, so you did a history on a patient, you did an exam, took x-rays, now what? This is part of decision making. This is a key component when billing new patient codes. What are you going to do? Here are some of the choices. You may do ice, heat, EMS, traction, manual therapy, massage therapy, therapeutic exercises, neuromuscular reeducation, therapeutic activities. Are you going to order DME on day one, or are you going to wait a little while? You're going to take x-rays on day one, or wait? You're going to send the patient out for an NCV or an EMG, or are you going to wait a couple of weeks? Refer the patient out for a consultation, chiropractic, obviously, acupuncture, strapping and casting, kinesiotaping, orthotics. You're going to do functional evaluations in office, or maybe you'll have a mobile diagnostic testing company come in. Trigger point therapy, lab work, weight loss programs, nutritional consultations, re-exams. So there's a lot that goes into making a decision on a patient. Which services you're going to do. You shouldn't be doing services just because they can make you the most money. That would be violating the definition of medical necessity. So let's go through a few of the most common billing codes. If you bring on a physical therapist, you're going to be billing these. These will be the first codes you bill, 97001, a physical therapy evaluation, and then a reevaluation is 002. So let's talk about these. CPT codes 97001 and 97002. They're different than E&M codes. E&M codes can be billed by chiros and MDs and DOs and NPs and PAs, but not by PTs. PTs cannot bill E&M codes. PTs can only bill PT evaluation and reevaluation codes. That's the 97001 and 97002. These codes may be only used in addition to other services if significant enough to report and require separate effort from the provider in addition to the other procedures. These PT eval and reeval codes should not be used with modifier 25. 25 is only used on E&M codes. So 97001 is used to report a physical therapy episode of care at the beginning of the episode of care. So this evaluation should document the necessity for a course of therapy through objective findings, subjective findings, diagnostic tests. Only a clinician, not like a chiropractic assistant, a medical assistant, an aide, an unlicensed healthcare professional. No, those individuals cannot do an initial evaluation on a patient or reevaluation. The documentation of this evaluation should list the conditions, complexities, and describe the impact of the conditions and complexities on the prognosis and plan for treatment. So this evaluation is going to include a diagnosis, description of the problem, history, exam, decision-making, diagnosis, goals, the services that are going to be rendered, frequency and duration. Now, the amount of time spent doing the evaluation is not billed in treatment time, so these are not timed codes. Evaluations and reevaluations are not time codes, but you are required to report the amount of time you spend doing the evals and reevaluations, but they're not based on time. If it takes 20 minutes, 30 minutes, 40 minutes, or 50 minutes, you're going to bill the same code and the same fee. Now, a little bit about 97002. This is intended to describe a reevaluation provided on a subsequent date of service. Reevaluations can be performed on more than one date of service during the episode of care. However, they are typically not done on every visit. They should not be billed on every visit. Reevaluations usually focus on the current treatment, and they're not as extensive as the initial evaluation. Continuous assessment of the patient's progress is part of ongoing therapy services and is not payable as a reevaluation. So a reevaluation is not a routine situation. You don't do it on every visit. Why would you do a reevaluation? New findings, change in the patient's condition, they're not getting better as fast as you would like. A reevaluation could be done prior to planned discharge. Again, reevaluations are not billed based on minutes. So the pre-service work for a new evaluation includes coordination or discussion with other team members, review of any records, tests. Intra-service work involves examining the patient, performing the service, obtaining data, organizing and interpreting the data. And then the post-service work includes documenting what was done and maybe communicating what's happening with the patient with a caregiver, a relative, an aide, talking to this patient's family member about patient's home care instructions. And with 97002, the reevaluation is pretty similar. Pre-service work, obtaining information, speaking to other healthcare professionals. Intra-service work is examining the patient, reevaluating their situation, organizing and interpreting the data, developing a new plan of care. Post-service work, that's when you're going to document everything that was done, and you may have to communicate with the patient's caregiver, aide, family member. Now, let's go through some of the common modalities: hot and cold packs, traction, unattended stim, all the modalities you see on your screen. These are non-time-based. Constant attendance is not required, even though they're considered supervised modalities. You don't have to stay with the patient. Supervised meaning personal supervision, not direct, not general. So you don't have to be in the room with the patient, but you cannot be in another building, cannot leave the office. So you have to be somewhere in the office, and you could have someone else performing these services. Or you can put the patient on hot packs, traction, electrical stim, and you can walk away. You don't have to stay with the patient. They're unattended, and they're not timed. Any questions on these, let us know at the end of today's webinar. And now we have constant attendance modalities: attended stim, contrast baths, ultrasound, 97035. That has to be constant attendance. You have to give the, you have to use the ultrasound transducer on the patient. So these are attended therapies. These are timed codes. Check discountmedicalsupplies.com for electrical stim machines and ultrasound devices. And now we have the therapeutic procedure services. These are different than modalities. Therapeutic procedures are not based on a device. They're based on your intended outcome. So we have therapeutic exercises, neuromuscular reeducation, aquatic therapy with therapeutic exercises. That code, the patient has to be in a water environment, gait training, massage. We have an unlisted therapeutic procedure, manual therapy techniques. Any questions on these, please send your questions in to Discount Medical Supplies, or you can send your questions directly to info@targetcoding.com. Remember, this is a introduction. This is a 40-minute or so webinar. We don't have time in this setting to go through all of these codes in detail, so just giving you some basic information. Again, these are timed codes. They could be billed in units. 1 unit is 8 to 22 minutes. This is according to Medicare. 1 unit is 8 to 22 minutes. 2 units is 23 to 37. 3 units is 38 to 52. 4 units is 53 minutes to 67 minutes. These are the Medicare guidelines. You may be in network with a plan that requires each service be done for 15 minutes. And if it's not done for 15 minutes, you may not be able to bill it at all, or you may have to put a 52 modifier. You may have to lower your fee. So you have to check with the plan. Part of compliance, which is what we emphasize strongly at Target Coding, means you have to follow the insurance company policy guidelines. especially if you're in network. Manual therapy, if you're a chiropractor listening to this presentation, remember manual therapy has to be done in a separate anatomic site than the chiropractic adjustment, or else you won't get paid. If you're performing services in an open setting, group therapy, 97150, is important. Therapeutic activities is considered the ING code, I-N-G, as it relates to bending, lifting, reaching, standing. Very different than 97110. A lot of people get confused on the difference between therapeutic exercises and therapeutic activities. 97535 is a very good code where you could show patients how to do things at home. Home care instructions are very important. When it comes to billing out for PT services, you want to be able to prove that you're giving the patient home care instructions. Physical performance test is an excellent way to do a functional capacity evaluation on a patient to see what type of exercise they can do. It's also great to be able to monitor a patient's progress. A few other items that are seen in many multi-specialty practices are NCVs and EMGs and trigger point injections, just to name a few. So let's go through a few of these. First of all, these codes that you see coming up on your screen have been deleted. As of December 31st, 2012, when the clock strikes midnight on December 31st, 2012, these codes will be deleted. Bye-bye. No more 95900, 95903, 95904, 95934, and 95936. Those codes are being deleted or have been deleted. Make sure that you're aware of this. If you're using these in your practice or if you're using an outside diagnostic testing company, 95905 is still in effect. Now, the new codes that are in place for NCVs are 95907 through 95913. Those are the new NCV CPT codes. Now, again, if you're billing insurance, you should be aware of that particular insurance company's policy. Here's an example of Aetna's policy on NCVs. This is just one page. I think it's about 15 pages of information. And it tells you what they feel is necessary, what they would want to see, what's not medically necessary for certain things regarding NCVs. So you should read these policies and be aware of them. Next, we have EMGs, needle EMGs. Please make sure if you're using like the subluxation station or the other companies, trying to think of the other company that does, dynamic EMGs, so MyoVision. So subluxation station, MyoVision, a few companies that sell surface EMG. You cannot bill needle EMG codes. There's so many doctors that I've seen billing needle EMG codes when they're using surface EMG. They're getting paid. One little audit on that, you're going to have to give all the money back. These are needle EMG codes. You're penetrating the skin. These are painful. These are messy. I've had these done in my practice. Patients are not happy when they're finished getting a needle EMG. But most insurance companies pay for these. Medicare pays for needle EMGs. These are the codes. These are some of the codes you see on your screen. Here's a few more. 95868, 95869, 95870, 95872. So just from a compliance standpoint, if you have a medical doctor in your practice doing these, make sure the medical doctor knows what these are. Send your medical doctor to a course on electrodiagnostics. Maybe you want to bring in a company Maybe you want to bring in a local chiropractor that's certified in electrodiagnostics, a certified electrodiagnostic technician, a chiropractor that's board certified in neurology. These are some of the companies that can come in and do these tests on your patients. If you're going to have any outside company come in, make sure your lawyer reviews the agreement. Make sure your state board has given you the blessings that you can do it. Here's some more needle EMG codes. 95885, 95886, 95887. Next, trigger point injections. Very effective service. Here are the CPT codes 20550, 20551, 20552, and 20553. Check the policies on the patients that are coming in, the patient's insurance policies. Check the fee schedules. Find out if the particular provider that's performing them is allowed to perform in your state, is credentialed through the plan that you're billing. And these can be very, very effective, and they can be a great income resource. Okay, just a few closing comments. You must check with all the carriers you bill prior to submitting claims based on the information provided in this presentation to ensure that it is compliant. You must check with your local state board, state association, and a healthcare attorney before you start your multi-specialty practice corporations and billing and coding. Target coding does not guarantee that the information provided in this presentation will guarantee payment from any insurance carrier or patient. Target coding is not responsible for any insurance carrier or managed care organization laws, rules, and guidelines that may change following you listening to this presentation. Please understand that insurance carrier rules, laws, guidelines, and regulations change. So it's important to do your best to stay on top of any changes that may occur by attending seminars, webinars, and joining your national and state professional associations.